So immune-acquired hemolytic causes and non-immune-acquired hemolytic disorders. So a lot of the disorders will either be immune-based, where the destruction of the red cell has an immunological basis. And then you have the non-immune causes, as you see a lot of infections fall in the non-immune acquired hemolysis, all right? So I've just put there this disorder, which is an acquired disorder that you cannot classify within the two, and this is a condition called paroxysmal nocturnal hemoglobinuria, which is an intrinsic membrane deficiency of certain proteins that leads to hemolysis. It's a rare disorder, and I've just put it there because some of you may come across it when you're reading, and you'll see it's actually a membrane disorder, and it's an acquired disorder. All right. So let's look at these disorders that have an immune basis of hemolysis. All right, so this is just sort of like a summary, a diagrammatic summary of these environmental causes that may cause red cell damage or hemolysis, or whichever word you want to look at. All right, so you can have, let's say, antibodies that have an immune mediated destruction of the red cell, and we're going to look at examples of that. You can have toxins or chemicals or drugs that are circulating within the plasma that can lead to direct destruction of the red cell, either interfering with the metabolic pathways of the red cell or even injuring the red cell membrane. You can have infectious agents that form or cause direct damage to the red cell. Then remember, we talked about the spleen. When it is enlarged, red cells can sequestrate into the enlarged spleen. And remember, when red cells sequestrate in the spleen, they are subjected to environmental and macrophage challenge, and the ones that are not able to survive or will be sequestrated and destroyed within the spleen. Right? Then you can have abnormalities within the vessel walls that the red cells circulate in, where you have, let's say, fibrin strands or vessel abnormalities that are unfriendly to the red cell, the circulating red cell, and the red cell can be damaged when it interacts with the vessel wall, and you get hemolysis of red cells. So this is sort of like a summary of the abnormal or pathological environment or micro ecosystem of the red cell that may cause damage and premature destruction of the red cell, right? So for immune mediated, of course, the basis is usually production of antibodies or that will destroy the red cell, and then you can have coating of the red cell with antibodies, and of course recognition by the macrophages, and then they are phagocytosed and destroyed. So let's look at immune hemolysis. So this immune hemolysis is usually due to production of antibodies against red cell antigens. And these antibodies, we can usually detect them in the laboratory, and you're going to be told about the techniques that we have in detecting antibodies in the laboratory, mainly the immune, the Coombs test, or the anti-human globulin test that we use in the laboratory to detect antibodies. So these antibodies can be directed against various antigens, and remember, antigens are proteins on the red cell that are able to evoke an immune response. And this means that antibodies are produced against specific red cell antigens, and the antibodies coat the red cell. They are recognized by the reticuloendothelial cells, the macrophages, especially within the spleen, and then the red cell is phagocytosed and destroyed either via the complement system. Okay, so what is the nature of these antibodies? These antibodies can be autoimmune, and autoimmune means that there is no external factor that promotes this production of the antibody to own red cells. So for some pathological conditions or pathological disorders, you get an individual producing autoimmune antibodies against own red cell antigens. And these conditions, there are very many diseases where patients that have an autoimmune basis. So we call this autoimmune disease. And as you begin to go through certain pathological conditions or the medical conditions that where patients develop an autoimmune condition where the body produces antibodies against own proteins. And I'll give you an example of some of these diseases. There are very many that are categorized as autoimmune diseases. For example, I don't know whether some of you have heard of systemic lupus erythematosus, rheumatoid arthritis, a lot of connective tissue disorders that is going to form you're going to have, when you study autoimmune disease, you're going to go through different types of diseases, examples of these diseases, where patients develop antibodies against own proteins. So a lot of these diseases, the antibodies, you can get antibodies against, let's say, smooth muscle, antibodies against, let's say, kidney cell, antibodies like antigens, like for example in systemic lupus erythematosus, you know that patients also have renal disease because the antibodies they produce destroy their own cells. So in autoimmune hemolytic anemias, a lot of them are associated with autoimmune disease, and patients produce antibodies against own red cell antigens. All right. And if these autoantibodies are produced, then of course they cut their own red cells, and then patients destroy their own red cells, and you get hemolysis, and it can result in anemias, and we call that autoimmune hemolytic anemia. All right. So in autoimmune hemolytic anemia, the sources of the antibodies against red cells are our own antibodies, all right, our autoimmune antibodies. So opposed to or different from autoimmune hemolytic anemia, you have alloimmune. So alloimmune antibodies are antibodies that an individual produces when provoked by an outside foreign substance, for example. Like, for example, a very good example of these are drugs, all right? So one of the side effects when you do your pharmacology, one of the side effects of some of the drugs is that when a patient is taking drugs, for example, for some other condition, and a good example of this that I can give is a common drug that is used in the treatment of hypertension, and this drug is called methyl dopa. It's not so commonly used now because we have newer antihypertensive drugs that are being used. But methyl dopa, when it was being used, it was noticed that patients can develop red cell hemolysis. And it was found out that methyl dopa induces antibodies that cross-react with red cell antigens and cause hemolysis. So in that, we say that this is an alloimmune antibody that has been provoked by ingestion or use of methyl dopa that evokes antibodies that cross-react with red cell antigens, and this can cause hemolysis. So, and there are many causes of alloimmune hemolysis. Of course, one of the commonest causes in medical practice is if, for example, you're transfused with blood that is not compatible with your ABO or your rhesus or the other blood groups, because there are many other blood groups apart from ABO and rhesus. So if you are transfused with incompatible blood, that is, you can produce antibodies against those against the transfused blood or your own blood, and you get hemolysis. And that is a topic that you're going to do when you do blood transfusion in the third year. All right, so we call that alloimmune hemolysis. So at an incompatible blood transfusion reaction is an alloimmune hemolysis, because the antibodies have been provoked by the transfusion of the foreign red cells that have been transfused into the recipient. Right? So that's a second good example of alloimmune hemolysis. So drugs and incompatible blood transfusion are good examples of alloimmune hemolysis, because the alloimmune antibodies have been produced against an external provocation by introduction of foreign proteins which are on, let's say, the red cells or the drugs, right? Now, then there is drug-induced hemolysis, which do not produce autoimmune antibodies, but what they do is that when you take certain drugs, these drugs can form carrier proteins, or they attach themselves on the red cells. And then if the body produces antibodies against these drugs that are attached onto the red cells, then antibodies are produced to the drug, but because the drug is attached onto the red cell, then the red cell is destroyed. Okay, so this is different from the drugs that will induce an autoimmune antibody, right? Because here the red cell is mainly just a carrier, all right? And the drugs are just the red cells are innocent, all right? The drugs coat the red cells, and if they are antibodies that are produced against the drug, then the red cell is destroyed by virtue of the fact that the drug has coated the red cells, all right? I hope we understand those two differences between the autoimmune type and the drug-induced hemolysis, the third one, all right? So antibodies that are produced against the red cells. And I've given you the various scenarios in which you can get antibodies produced against red cell proteins or red cell antigens. And remember, antigens are mainly protein carbohydrate complexes. And the fact that they're called antigens is because they have a capacity to induce an antibody production. All right. So any substance in the body that has the capacity to induce antibody production is called an antigen. All right. Antigens have various, they're mainly protein based substances, but they can be complex in terms of they may be complexed with carbohydrate or even lipid substances, all right? But their basic nature is that they're able to induce an antibody response. And so those substances or these antigens are said to be immunogenic. All right. Okay. So if we look at the mechanisms, all right, if we go just a little bit into details of how do these antibodies destroy the red cells, all right? So the mechanisms of RBC destruction, and I'm sure in your immunological mechanisms that you've learned in your lectures in immunopathology. You've learned about cell-mediated immune destruction. And cell-mediated immune destruction means that the red cells are usually destroyed extravascular. And the extravascular site of destruction is usually within the spleen. So what this means is that when you get antibodies, whether they are autoimmune, alloimmune, or whether they are, drug-induced, where they coat the red cells, these, as the cells that have, as the antibodies attach onto the red cell, as they circulate within the spleen, they are recognized by macrophages, all right, as foreign, all right? Because remember, the antibodies, you have cells that recognize the antibodies as and they can be phagocytosed within the spleen by macrophages, all right? And we call that cell-mediated destruction of the red cells. Then you can have complement-mediated destruction. And complement-mediated destruction, you know that, I don't know whether you've done this, but you know that there are antibodies that induce complement activation. And these are usually IgG and IgM antibodies, all right? And this can stimulate complement activation. And when you get the complement activation, you get production of an immune complex, which is called the MAC, the membrane attack complex. And these lyse red cells within circulation. And this causes intravascular hemolysis. So these are the two mechanisms. So the cell-mediated destruction usually leads to extravascular hemolysis within, or destruction within the spleen. For antibodies that are IgG, that the antibodies produced that are of IgG type and IgM type, usually activate complement, and this leads to intravascular hemolysis. So this is just what I've talked about. You get sensitization of RBCs by immunoglobulins, and they're usually of IgG type, and these are destroyed or phagocytosed by reticuloendothelial cells, which are mainly in the tissue macrophages. And remember, tissue macrophages usually express receptors of the Fc portion of the immunoglobulin G or IgG molecule, and the coated red cells are recognized by the tissue macrophages, which of course are part of the reticuloendothelial cells, and the red cells are phagocytosed and destroyed. All right, so that's the cell-mediated immune intravascular. All right. So in immune-mediated destruction, remember there's complement 1 activation, and usually by IgM. All right, and the red cell is usually destroyed through two mechanisms. So you get direct complement-induced cytolysis or cytotoxic action by massive activation of complement 1. And the complement activation is followed by recognition of complement 3 degradation products on the red cell by specific receptors of the reticuloendothelial cells. And these are usually, the key players here are usually the reticuloendothelial cells that are in the liver, which are called the Kupffer cells, and you get the destruction. All right, so this gives you intravascular hemolysis because of direct complement 1 induced cytotoxic with massive activation of the complement, and then you can get a complement 3 recognizing the activated complement 1, and degradation, and the degradation products are also recognized by these reticuloendothelial cells of mainly the liver, all right? So that's sort of like a brief pathophysiology of what happens in complement activation and the cell-mediated activation. So that is about immune hemolysis, all right? So this is just a diagrammatic representation of what I've been talking about and how antibodies are recognized by the antigens on the red cell, and you get either cell-mediated immune hemolysis, or you get intravascular complement-mediated activation with cell cytotoxicity within the circulation, right? Okay, this is just the similar, diagrammatic representation, because usually what happens is the complement destroys the red cell membrane, and the red cell membrane becomes compromised, and you get it attracting extracellular fluid because it's not able to maintain its turgidity, and the extracellular fluids are the ones that actually cause the red cell lysis. So maybe just as an introduction, I'll tell you some of the causes of autoimmune hemolytic anemia. And these are some of the conditions that you're going to have lectures in your second year, in your third year, when you do internal medicine and you're looking at specific disorders like SLE, rheumatoid arthritis, Sjogren's disease. There are many of them, all right? And so these are just some examples of conditions that can lead to an individual producing antibodies or autoantibodies against own red cell antigens, and we call that autoimmune hemolytic anemia, all right? So causes can be either idiopathic, where you don't know what causes or what induces a person to just begin producing red cells. You investigate the patient and you don't see any cause, so we call that idiopathic. Then you can get autoimmune as a complication of many diseases. And remember, I gave you an example of an immune disease, and I told you about SLE, which is systemic lupus erythematosus, which is a common autoimmune disease. You can also get antibodies produced due to certain cancers, and especially cancers of the lymphoid system, like lymphomas, chronic lymphocytic leukemias. You're going to have lectures on all these, and we know that, like, for example, some lymphomas or malignancies called lymphomas, patients can have an autoimmune related hemolytic anemia accompanying this disease, this malignancy, all right? And autoimmune hemolysis can also be associated with certain infections, certain viral infections, where patients suddenly develop red cell hemolysis, which is immune-based due to production of antibodies against own antigens. And then, like in mycoplasma is a special, or rather a sort of a different bacterial infectious organism that gives you what is called mycoplasma pneumonia. And we know that patients who have mycoplasma pneumonia can also develop autoimmune hemolytic anemia. So those are some of the medical conditions that are associated with patients developing immune antibodies against own red cell antigens. All right. Now, if you look at hemolysis, if you look at the nature of the antibodies, and this will be discussed very explicitly, or has already been discussed very explicitly by in immunology, antibodies can be of warm type or cold type, all right? And this classification of warm or cold is just based on the the maximum or the most convenient temperature that gives optimum antibody action. All right, so you'll find warm antibody types act best or are of high avidity at warm temperatures. And warm temperatures is like body temperature at around 37 degrees. So you find in the laboratory, if we suspect that a patient has a warm antibody hemolysis, we're going to try and detect that antibody at 37 degrees, all right? And we know that a lot of the warm antibody type hemolysis are usually of IgG type, all right? Now, cold antibodies are antibodies that react best at lower temperatures, and these lower temperatures are usually at 25 degrees, which is room temperature, and some of them even act best at very much lower temperatures like 4 degrees. So you'll find in the laboratory, again, we will try and detect these antibodies at those temperatures because that's when they act best, all right? And where it is also noted that warm antibody type are usually the ones associated with extravascular hemolysis, which occurs in the spleen, as I have already explained. And cold antibodies usually are associated with intravascular hemolysis, where the hemolysis occurs within circulation, and they're usually of IgM type, and of course, they're the ones that fix complement. All right. So second years, I hope you're still with me. Hello.
We are still here.
Okay, thank you. Because sometimes it can seem like you're talking to no one. All right, so good. You're still you're still on the lecture with me. All right, and as I said, any questions can be put on the chat, and we'll try and see if we can answer them quickly before your practical that will start at around 9:30 with Mr. Jackson. All right. So moving ahead, alloimmune. I've already talked about this alloimmune. All right, I've given you examples. And best example is hemolytic transfusion reaction, where it should be used with cells, or rhesus, or other that you're going to have in much more detail, I think, in the third year. Then we have hemolytic disease of the newborn, and this is usually ABO or rhesus incompatibility between mother and fetus. Again, another lecture that you're going to have on hemolytic disease of the newborn, which will be handled in third year. You'll also get to hear about it in pediatrics when you're doing your pediatric rotation. And again, it will be handled by obstetricians and when you're doing obstetrics and gynecology. Because this is one of their major problems which are seen during pregnancy and at birth, all right? So these will be handled again, but these are good examples of alloimmune hemolytic anemia and transplant-associated hemolytic anemia. In transplantation medicine, renal, or any other transplant, one of the anticipated complications can be transplantation associated hemolysis, and this has a lot of the multifactorial causes as part of graft versus host disease, or even the drugs that are used. All right, so transplantation associated hemolytic disease. Good examples of alloimmune hemolytic anemia. All right, so drug-induced immune anemia, many drugs. Again, this is going to be handled in third year when we specifically look at certain drugs that one of the complications or one of the side effects of these drugs is drug-induced immune anemia. Mechanisms are different. Some, like I said, some drugs can induce autoimmune antibodies or can induce an individual to produce antibodies directly attacking their own red cells, or drugs can coat red cells and that complex of the drug and the red cell can induce antibodies that may be directed against the drugs, and then the red cell is destroyed innocently. So I've just given some examples of some of the drugs that you will come across when you're doing your pharmacology that are associated with immune hemolysis as a side effect of the drug or an adverse effect of the drugs, like cephalosporins. And cephalosporins are antibiotics that are used in a lot of infections, urinary tract infection, chest infections. We use cephalosporins. There are many different types of cephalosporins. We have methyl dopa or levodopa that are antihypertensive, penicillin-based drugs, and penicillin and other penicillin-derived drugs like meropenem, methicillin are drugs that are used in treatment of a lot of infections. Quinidine, and other drugs like the non-steroidal anti-inflammatory drugs, the NSAIDs, aspirin, and related drugs, paracetamol, all non-steroidal anti-inflammatory drugs can be associated with drug-induced hemolytic anemia. All right. Again, another lecture in third year, and you'll go into some of the specific mechanisms of these drugs. All right, so this is what I've talked about. Drugs may induce true autoantibodies, or drugs may induce specific antibodies against its drug, and you get the red cell being damaged, when you get a drug antibody complex. I think I've already explained that. All right. So much for immune hemolysis. All right, and I hope those examples are clear. Immune hemolysis, autoimmune, and alloimmune. And I've given you some of the mechanisms that can lead to immune hemolysis in terms of extravascular hemolysis within the spleen and complement-mediated hemolysis that usually occurs in intravascular. All right, so let's look now at non-immune mechanisms. All right, so non-immune mechanisms are arbitrarily classified, or the classification is arbitrarily. You can have what we call red cell fragmentation syndromes, and red cell fragmentation syndromes give rise to what is called microangiopathic hemolytic anemia. And microangiopathy just means that red cells are damaged in small vessels, micro vessels, in microvascular. All right. So when we say microangiopathic hemolysis, the red cells are being damaged in small vessels because of abnormal vessel wall, where the red cell wall becomes damaged. Less you can have fibrin strands within these small vessels, and as the red cells circulate within those small vessels, the red cell membrane is damaged, and the red cell becomes fragmented and it is destroyed. And conditions where you can get microangiopathy is like hypertensive disease, patients who have malignant hypertension, and you're going to go through hypertension in anatomic pathology. They'll tell you about benign hypertension and malignant hypertension, or primary hypertension, secondary hypertension. I don't know whether you've already started having those classes. And one of the complications of malignant hypertension is microangiopathy. All right. So patients with hypertension can develop a hemolytic disease, and we call that microangiopathic hemolytic anemia. Other examples are conditions like DIC. DIC is a complication of many disorders. DIC stands for disseminated intravascular coagulopathy. Right? This is again another disorder, a complication that you're going to go through that complicates many disease conditions, and patients can develop microangiopathic hemolytic anemia. Then there is a condition called marchimoglobinuria, small vessels that may go repeated damage, for example, in marathon runners or long distance runners, or in soldiers, for example, that march for long periods. We know that the small vessels within their feet can be damaged, and mechanical damage because of mechanical trauma, and you can get what is called march hemoglobinuria, which is mechanical damage of red cells in small vessels in the limbs. Again, patients who have had cardiac valves or synthetic cardiac valves, and remember, different materials are used to make synthetic cardiac valves for patients who have valve disease. Can as the red cells circulate through this pass in the heart, as the red cells circulate through the prosthetic valve that has heart disease, for example, the red cells can be destroyed and they get microangiopathy. And then there is so those are some of the examples of microangiopathic or red cell fragmentation syndromes, and these are non-immune related hemolysis. Then we go to infections, many infections associated with hemolysis, and of course, the commonest and most prevalent here is malaria, and that's how malaria causes hemolysis. Of course, malaria, is an intracorpuscular parasite, and that survives. It's got one of its stages within the red cell, and parasitized malaria cells are of course recognized as abnormal and are hemolyzed within the spleen. Right? Babesia is also an infectious agent, which is it's parasitic. It's not very common in these are all protozoas. Remember, malaria is a protozoa. Babesia is also a protozoa. It's not very common. Babesiosis is not very common within this region. It's mainly common in South America and other parts of desert areas in the Americas, and it can give you a hemolytic process. All right, not very common here. Example, hemolysis, where just give me 1 minute, please. So another infection is Bartonella infection, which is an intracellular bacteria that can give hemolysis. And then in Clostridium infection, like Clostridium sepsis, you can also get direct injury to the red cell, and you get subsequent destruction or hemolysis. So those are some of the infectious agents that can give you hemolysis. Over and above, the most, of course, important is malaria, because malaria is endemic here, and we do get epidemics of malaria, especially in children. All right, gives you hemolysis. All right. Then we have examples of chemicals that can give you hemolysis, many examples of chemical agents, other drugs that cause direct non-immune injury to red cells, snake venoms or spider venoms that give direct biochemical or damage to the red cell, and this causes oxidant damage to the red cell membrane, and there are many examples of that. All right, so snake bites, spider venoms, and then you have chemicals that give you non-oxidant damage like arsen, lead, copper, even water can give you non-oxidant damage to the red cell membrane and gives you hemolysis or destruction of the red cells. All right. Then you have chemicals that give you oxidant damage, and I think when you went through enzymopathies, like patients who have G6PD deficiency have a tendency to get oxidant damage to the red cells when they're exposed to certain drugs, like dapsone. Dapsone is a drug that is used to treat leprosy, for example, and other drugs like sulfasalazine can give you oxidant damage to red cells, and more so in patients who have G6PD deficiency. All right, so chemicals, agents, and drug venoms, those are some of the examples. Then you have physical agents like thermal injury, ionizing radiation. We know all these can give you hemolysis. Okay, so as the last slide, I think, or just before we look at quickly through investigations, because I know you've already done that. Hypersplenism occurs in patients who have enlarged spleens, and as the red cells circulate through this enlarged spleen, they can sequestrate, and first of all, you get damage of red cells that are abnormal, all right, or old cells are damaged first as they circulate through this enlarged spleen, and sometimes even normal cells can be destroyed, and patients usually get what we call sequestration, hypersplenism, and they get because macrophages within the enlarged spleen and that or a process that is seen in patients who have enlarged spleen, right? So patients with splenomegaly can get sequestration and they get hypersplenism. It's a hemolytic process. All right, so PNH, I'm sure this has been handled before. It's an acquired hemolysis where patients have an acquired disorder that gives them abnormal red cell membranes, and they are at high risk of complement activation and complement destruction of the red cell. All right, and it's the basic abnormality is a deficiency of a certain complex, which is a glycophosphatidyl linosytyl a component of the red cell. They have that deficiency of this particular substance puts them at risk of red cell destruction through complement activation. It's an acquired disorder. Right. So this particular condition is quite rare, not very common. It's actually quite rare. We don't see it very often, but it's called paroxysmal nocturnal hemoglobinuria. So in the laboratory workup of patients with hemolytic anemia, I think you are given 3 basic principles in the way we investigate hemolytic anemia. First of all, if a patient comes with an anemia or hemolysis, is it hemolytic? So what do we do to find out whether there's hemolysis going on? All right. And then the way we want to also investigate is that if it is hemolytic, where is this hemolysis taking place? Is it intravascular or is it extravascular within the spleen? All right. And then after you've done that, what is the cause? Is it drug? Is it malaria? Is it immune? Is it autoimmune? Then you do tests to find out that, so that you can treat the patient appropriately. So in the initial investigations, we look at the full blood count, and of course, you're going to look at what the red cell looks like. You're going to look at the red cell indices and the red cell values and parameters, all right, which I've listed there. The second investigation is to look at reticulocyte count, and I'm sure you went through this. You know that in hemolytic anemia, or where you have destruction of the red cell, reticulocytes rise, they go up. And you know the normal reference value of reticulocyte count in children and in adults, okay? So you'll find, for example, in adults, it's usually between 0.5 to 2%. And so in hemolysis, this count can go up to 5%, 6%, and we're able to do a reticulocyte count in the laboratory in blood samples. And the relevance of reticulocyte count is that it shows you that there is an increased erythropoietic capacity or activity, because the bone marrow is responding to the destruction of red cells, all right? So you get a reticulocytosis. Then we look at the blood film, all right? We look at morphological changes, and sometimes these morphological changes can tell us what is happening, all right? For example, if there's malaria infection, you see malaria in the red cell, and you're able to make a diagnosis straight away that what is causing this hemolytic anemia is malaria infection, and you treat the patient. You prescribe antimalarials and treat the patient. There are other non-specific morphological changes that occur in peripheral blood film examination. Like, for example, you can see fragments in the fragmentation syndromes. And remember, we saw some examples of fragments when we went through red cell morphological defects, the schistocytes, the burst cells, the acanthocytes, all those are red cell fragments, all right? Spherocytes occur in immune hemolysis, and I think we showed you pictures of spherocytes, okay? So looking at peripheral blood film gives you evidence of hemolysis, and also can even be diagnostic, like say when you see malaria. And then nucleated red cells is also a bone marrow response, where it extrudes nucleated red cells into circulation as a response to the immune hemolysis, or any other type of hemolysis, when the erythropoietic capacity is overtaken and nucleated red cells are extruded into circulation to try and compensate for the red cell destruction. Then you can have biochemical tests of hemolysis, and I'm sure you've gone through this. Usually you can have increased in indirect bilirubin, because you know that hemolysis is a cause of indirect bilirubinemia. Lactate dehydrogenase is also increased because we know red cells have a lot of LDH, lactate dehydrogenase, and when they are destroyed, especially in extravascular hemolysis, then the LDH level rises. Haptoglobulin and hemopexin, you know that haptoglobulin binds free hemoglobin, right? And we know that free hemoglobin is toxic to renal cells. So the body has this protein that complexes with free hemoglobin, and then the free hemoglobin is excreted, and this protects the renal cells from damage by free hemoglobin. So usually in hemolysis, haptoglobulin decreases because it complexes with free hemoglobin for excretion. Hemopexin also is a smaller concentration a protein that also complexes with altered or oxidated hemoglobin and for excretion. So also that decreases. And then when you look at a urine sample, you can detect hemosiderin. You can get hemoglobinuria. You can get free hemoglobin in urine. If the hemoglobin, if the haptoglobulin has been decreased to a level now that you can get also the hemoglobin level, the free hemoglobin levels have exhausted the amount of hemoglobin, you get free hemoglobin being extruded or excreted within the urine. So you get hemoglobinuria. And you can also get urobilinogen, which is a bilirubin excreted in urine. So all these go up. You can detect them in the urine. And these are the biochemical markers of hemolysis. Okay, then at the end of that, of course, you want to find out what is causing the hemolysis. And remember, we've looked at immune, we've looked at autoimmune and alloimmune, we've looked at the non-immune causes. So of course, you want to find out what is the specific pathological cause or disease that is giving you the hemolysis. And there are laboratory tests that can direct you, which are directed usually by the clinical history of the patient. They're directed by the physical examination that you do as a doctor, and also by other preliminary tests that you have done. And then you can now say, look, if this is an immune hemolysis, is there an antibody? So you do a Coombs test, which is Coombs test is also called direct antiglobulin test, all right, which is usually done in immune-mediated hemolysis. Then if there's an antibody, there are tests that you can use to identify the antibody. And once you identify the antibody, it is usually known what type of antibodies can occur in certain diseases. So you look for that disease, all right? You can do drugs for drug-related or mediated hemolysis. For PNH, we do what's called Haemolysis test, but remember I told you PNH is quite rare, but we have what's called the Haemolysis test that we do in paroxysmal nocturnal hemoglobinuria, all right? The other name for Haemolysis test is serum acidified lysis test. You can do flow cytometry when you have also in PNH, and you can even, in patients where there's hemolysis, there are even you can do red cell survival test where you label patients with radioactive chromium, for example. You label patients' red cells, and you can study the circulation of the red cells and the destruction of the red cells. And this can give you, can allow you to demonstrate whether there's a shortened red cell span and whether patients are hemolyzing. So specific tests are there for study of acquired red cell hemolysis. So I think you saw these before. These are just fragmented red cells. And I think I showed you some of this when we were looking at red cell morphological defects. So these ones, you would see them in microangiopathic hemolytic anemia, where you get fragmented red cells because of circulation on abnormal vessel. All right, this is a polychromasia as an indication of hemolysis. So we see this in peripheral blood films in hemolysis. And remember, polychromasia are usually actually reticulocytes. They are immature red cells released into circulation as a response by the bone marrow to hemolysis. All right, and then we have malaria, which is a very easy diagnosis to make. You can, just making a peripheral blood film, staining it with appropriate stains, you can see the malaria parasites within the red cell. And these are tests that are done in any hospital. They're very simple tests to do and very cheap, and you make a quick diagnosis of malaria. All right, so you can see various stages, the ring forms, you can see the gametocytes over here, and these are the ring forms. And you can even say which species the malaria is. Okay, so that's the end of my lecture. It's 9:25, and class rep, you can now link up with Jackson, and he can just take you through some of the basic practical aspects. I think this is the first practical for the second year class. and you're going to go through some of the laboratory techniques that you have been introduced to from the beginning of the hematology lecture series. So I don't know whether there is any burning questions, but that is the end of the lecture. Let me just look and see if I can respond quickly to one of these. So in case of alloimmune, does hemolysis occur to the recipient cells or only to the donated blood? So that's a very good question. The hemolysis will occur in both the depending on the antibody type. The hemolysis will occur in both the donated cells and also the patient cells, all right? Depending on the antibody that is produced. Okay. And you're going to have a full lecture on hemolytic transfusion disease. All right. You have acute hemolytic blood transfusion reaction that is usually a rhesus or ABO incompatible, and usually a lot of the ABO compatibility gives you mild disease, but rhesus incompatibility gives you very severe hemolysis. Then you have other antibodies that can also give you hemolysis, right? So you can have hemolysis depending on the antibody that is produced and the type of incompatibility that is there, whether it is rhesus or ABO or any of the other minor blood groups like KEL. You can get destruction mainly of the recipient cells, but you also get destruction of the transfused cells. All right, because in preformed antibodies, like for example, we know that the ABO antibodies, I'll give you an example. If you're blood group A, it means that you have B antibodies already formed circulating in your plasma, all right? You're going to go through that. We call that those natural antibodies, all right? And if you're predisposed, if you're given B cells, then your B antibodies canalize the transfused B cells, all right? So this will become very clear when you do blood group serology, which are the lectures towards the end of this hematology series, and then you will go more into transfusion-related hemolysis in third year. Then you'll be able to understand the meaning of natural antibodies versus immune antibodies. Okay, so as Ruheni asks, okay, I don't know what that means. She said the drug is carried by the RBC, so the RBC injured as a collateral damage. I think maybe you were explaining that to somebody. So would you please repeat the complement intravascular thing? All right. Have you done the complement system? Hello? Have you learned the complement system in immunology? Second years?
Yes.
Are you there?
Yes, we have.
Okay, so who is Valentine? Is Joely's friend? Can maybe somebody who is Joely's friend can, because you need to know the complement system, all right? You need to know about the complement system, the proteins that make up the complement system, and how it's activated by usually IgM, and the activation results in formation of the what we call MAC, the membrane attack complex, all right, which is a C3 complex, and these gives direct damage to red cells. or cell cytotoxicity. So you need to know, you need to open a book and look at the complement system and how it is activated. Joelle, I hope that, and if you look at it and read it and see what it is, all right, I can't go into the details now, and it's also a lecture that you have in immunopathology, then you will understand how complement mediated red cell damage occurs. Okay, so revision of the complement system. What is RES, Philip? RES stands for reticular endothelial system, and this is a system of cells which are mainly the monocyte macrophage system, and there are many types of cells, and they are given different names depending on in which organ they are. Like, for example, I said in the liver they're called Kupffer cells. In the skin they're called dendritic cells. In the bone marrow, there are macrophages and histiocytes. If you go to the brain, what are the equivalent of reticular endothelial cells in the brain? What are they called? This is histology now.
Microglia.
Microglia, excellent. And in the lung, what is the equivalent of reticular endothelial in the lung?
Alveolar macrophages.
Alveolar macrophages. Okay, so Philip, that's the reticular endothelial system. All right. So revision for you, Philip. Okay, somebody has said reticular endothelial cells. I think, yes, you're thinking right, Ocheng. And we've had examples of reticular endothelial cells in brain, in liver, in spleen. All right. Okay. So everyone knows what reticular endothelial system. Philip, you've been assisted by your classmates. Julie, in immune hemolytic anemia are the antibodies from different individuals or are antibodies produced by. So in immune hemolysis, Julie, remember I said they can be autoimmune where the body produces antibodies to own antigens. In alloimmune, the provocation of the antibody production comes from the external. All right, it can be foreign. It can be a drug, for example. It can be a viral infection, for example. It can be like transfused red cells from another individual. So that is alloimmune. All right. Because I don't know, you say in alloimmune hemolysis, are the antibodies from different individuals or are the antibodies produced against foreign antigens from different individuals? So the antibodies are produced, they can be antibodies that are introduced into a person already preformed, maybe let me say that, or it can be a foreign individual substance that comes in form of a drug or comes in form of cells from another individual, all right? Or in form of a virus, for example, that comes into the body, and the antibodies that are produced against that particular foreign substance cross-react against the antigens in the person, in the patient that is where the hemolysis is going on, all right? So Julie, I hope I'm clear on that. Julie? Julie is not talking. So Julie, I hope I've answered your question. DIC, Jackie, stands for disseminated intravascular coagulation, and Sleepy has told you that. Okay, what exactly do you mean when you say that PNH condition is acquired? PNH is an acquired condition because what happens, when we say acquired, it means it's not congenital. You're not born with it, all right? Patients acquire a deficiency of that complex that we talk the mean you're not born with it, it's acquired. All right. Can we say that reticulocytosis is the same as polychromasia? Yes, you can, because the cells that stain and look polychromatic, in that they are bluish, they're usually, because remember, they're bluish because they take up this stain, and the reason they take up this stain is because they have a remnant reticuloendothelial, or rather reticular material, RNA material, and they're immature cells, and that's why they look polychromatic. All right. So usually, if you see polychromasia and you do a reticulocyte count, it's usually high. All right. So the reticulocytes stain polychromatic. All right. So you're actually right in saying that there's no name there. There's just student. All right. Please repeat haptoglobulin, why haptoglobulin reduces. Haptoglobulin complexes with free hemoglobin. So when you have intravascular hemolysis of red cells, remember, when the cell lyses, it releases hemoglobin, because the content of the red cell is hemoglobin. So when you get lysis, hemoglobin is released and it circulates free. And free circulating hemoglobin is very toxic to the glomerular cells in the kidney. So haptoglobulin complexes with the free hemoglobin, and then it is excreted in urine. So haptoglobulin sort of like protects the renal cells from damage by the free hemoglobin. And so if you have hemolysis and you have intravascular hemolysis, you have a lot of hemoglobin being produced, and so it complexes with the haptoglobulin, which is the protein that you have in circulation in your plasma, and of course it depletes it, isn't it? So that's why it decreases when you have intravascular hemolysis. So I hope, Tracy, that answers your question of why you get a reduced in haptoglobulin concentration in intravascular hemolytic conditions. Okay, I think we can end there. It's 9:40, so somebody can call Jackson so he can take you through a few of those laboratory techniques. So I'll stop sharing, and I think we can end the meeting there. If there are no more questions, I'm going to leave now.